Spironolactone is an aldosterone antagonist which acts on the cortical collecting duct. Indication are ascites, secondary hyperaldosteronism, use large doses 100 or 200 milligram, in hypertension, in heart failure, nephrotic syndrome, Cone syndrome. Adverse effect are hyperkalemia and gynecomastia, which is less common with eplerenone. Rales criteria NYHA 3 and 4, patient already taking ACE inhibitor, low dose spironolactone will likely decrease all causes of mortality. So this is how it's helpful in heart failure. SLE kidney complications, these are the stages. Type 1 is normal, type 2 is mesangial glomerulonephritis, type 3 is focal and segmental proliferative glomerulonephritis, type 4 is diffuse proliferative glomerulonephritis, most common and most severe form. Type 5 is diffuse proliferative membranous glomerulonephritis, and type 6 is sclerosing glomerulonephritis. Type 4 glomeruli, endothelial and mesangial proliferation is there. So this one is the one which is going to be asked in the exams. Most common and most severe form. There is granular appearance on immunofluorescence in diffuse proliferative glomerulonephritis. Plasma exchange complications, metabolic alkalosis, removal of systemic medications will be there, coagulation factor depletion and immunoglobulin depletion. Hypocalcemia, presence of citrate used as an anticoagulant will cause hypocalcemia in plasma exchange. Acute interstitial nephritis, the drugs which most commonly cause it is penicillin, rifampicin, NSAIDs, allopurinol, furosemide. Systemic disease like SLE, sarcoidosis, Sjogren's syndrome, infections like hantavirus, staphylococcus. Histologically, you will see interstitial edema or infiltrate in the connective tissue between the renal tubules. Clinical features will be fever, there will be rash, arthralgia, eosinophilia is very important to diagnose, and mild kidney failure with hypertension. Investigation, there will be sterile pyuria, white blood cells in the urine dip, white cell cast will be there. Now how to differentiate ATN from AIN with using the urine dip? Proteins, there will be renal cause, rule out pre-renal and post-renal causes. Increase in white cell, there is some inflammation in the interstitium. So the urine dip will help to differentiate between ATN and AIN. HUS, hemolytic uremic syndrome, I think so. Triad of AKI, acute kidney injury, microangiopathic hemolytic anemia, and thrombocytopenia. Thrombocytopenia is important to diagnose HUS. Most common secondary Shiga toxin producing E. coli STE C0157 is 2H7. The pneumococci, HIV, rarely SLE, drug or cancer can cause HUS. There is primary complete dysregulation of the kidney, I guess. Investigation, blood, platelet decreases, this is important to diagnose. Urine and electrolyte analysis, AKI. Stool, there will be evolution of STEK infection, PCR for Shiga toxin you can do. Management, fluids, blood transfusion, dialysis. There is no role of antibiotics in HUS. Plasma exchange for severe cases, which is not associated with diarrhea. Eculizumab, which is C5 inhibiting monoclonal antibody, has great efficiency in HUS. CKD anemia occurs when GFR is less than 35. If the GFR is more than 60 and the patient has got anemia, you have to look for other causes of anemia apart from CKD. There will be LV hypertrophy, left ventricular hypertrophy, and this increases the mortality by 3 times. The target hemoglobin in CKD patients is 10 to 12 gram per DL. You give IV iron, you give erythropoietin and darbepoetin. Proteinuria in CKD, you check the albumin creatinine ratio because it has got a greater sensitivity. Albumin creatinine ratio 30 is about 50 of PCR, and urine protein excretion of 0.5. 70 is 100, and urine protein excretion of 1 gram per 24 hours. ACR, you take a spot sample first pass, 3 to 70 confirm next day and repeat. If it is more than 70, then no need to repeat it. Interpretate ACR more than or equal to 3 mg per millimole, clinically important proteinuria. Refer to nephrologist if it is more than or equal to 70 and less known case of diabetes. More than or equal to 30 with hematuria, exclude UTI. 3 to 29 persistent hematuria decreases EGFR. Mark loss of facial tissue from face. Membranoproliferative glomerulonephritis type 2 with nephrotic syndrome. Treatment: ACE inhibitors or ARB, first line hypertension, ACR more than 30, and without hypertension, ACR more than 70.